Good morning, everyone. Welcome to Let's Talk Parkinson's online event brought to you by Parkinson's Community Los Angeles. Today, we're talking about the latest in Parkinson's research with Dr. Jeff Bronstein from UCLA. I'm Patrick Lasasso, president of PCLA. For those of you who don't know us, we're a Los Angeles-based nonprofit, and we've been serving an international audience through our free online educational events, support groups, information and referral program, and more. This series is brought to you by our Let's Talk Parkinson's sponsors, Abbott, AbbVie, Boston Scientific, Medtronic, and Synovian. Before we dive in, let's quickly review a few rules. We are recording today's event for our YouTube channel, so if you do not want to be visible, please turn your video off. You will receive a link to review the recording afterwards. Please keep yourself on mute. We'll have time for questions at the end. You can submit them into chat. And if typing is too difficult towards the end, if we have time, I'll be asking for verbal questions from the audience at that time. Please keep your questions on topic, and we'll try to answer other questions if there's extra time at the end. So our presenter today is Dr. Jeff Bronstein, Director of Movement Disorders Program at UCLA. His interests and expertise include the management of Parkinson's and movement disorders, surgical treatment of Parkinson's, and developing new therapies for patients. Dr. Bronstein's lab studies the cause of Parkinson's using cell models and a newly developed zebrafish model. His work is supported by the NIH and by grants from private foundations, and he also directs clinical trials in order to develop new therapies for Parkinson's that include transplantation and deep brain stimulation. Dr. Bronstein has received many awards and is widely published in the field, and we're very lucky to have him with us today. Thank you, Dr. Bronstein, for joining us.
Well, thanks, Patrick. That was the first time I heard your radio voice, so very good.
I'm going to mute my radio voice right now. Thank
you. Anyway, thanks so much. It's always a pleasure to be here. I decided to, we only have an hour, and those who know me know I can speak on anything for many hours. So I decided this time really to focus in on the new treatments. That's what most people are interested in. So things that are either recently developed or currently developed or under development. But I'm always happy to answer questions about the causes and the incidents and what's going on. So I can do that. So I shortened the talk, so we should have plenty of time for questions. I'm going to try to make it like about half questions and half the slides. If everybody could stay muted, that would be great to keep the background noise down for everybody. And then again, we'll have plenty of time for questions at the end. If you could keep the questions more general. So unfortunately, I'm not, it's not a good position for me to make specific recommendations on your medications. But if you have a general question that you think will be of interest to others who may be suffering, happy to address that in general. So let's start. I'm going to start sharing my slides and hope everybody can see this. So Patrick, can you nod if you see my slides? Yeah, okay, great. All right, so I'm just gonna again talk about treatments, and I wanna just do one. Okay, so when we talk about treatments, there really are, I think about it in three ways. We could avoid risk factors and do things ahead of time to prevent getting Parkinson's. This is something I'm not gonna really talk about today. We can talk about slowing the disease progression once you have the disease. People talk about that as either neuroprotection or disease modification. So I'm definitely going to talk about that. But then for those people who already have Parkinson's, we like to treat the symptoms and improve people's quality of life, and obviously talk a lot about that as well. It's important to realize that in medicine, we do a lot of this. When people have high blood pressure, we give a pill to lower their blood pressure. You stop the pill, the blood pressure comes back up again. So we really don't treat that many things successfully. We treat infections, some tumors. So this is a big challenge in all of medicine, is how do you change underlying disease processes? But there's some exciting things that are ongoing right now to be very optimistic about this. So we'll definitely talk a lot about that. So right now, our current therapies, no therapy really changes the course of the disease. Everything is symptomatic. And when everybody thinks about symptomatic treatments, we always think about dopamine. We increase dopamine. And that helps many of we call the cardinal symptoms of Parkinson's: stiffness, slowness, tremors, walking, having problems walking. But it really is just as important to think about all the other aspects of the disease we treat as well. It's just that they're more general. So for example, problems sleeping. Many people have insomnia, have problems sleeping, whether you have Parkinson's or not. It happens to be more prevalent in Parkinson's disease. So we treat that. Depression is very, very common in Parkinson's. Constipation, orthostatic hypotension, blood pressure dropping when you stand up. There are many symptoms that, not just the stiffness and slowness, the dopamine responsive symptoms. We focus again on that because those are quite specific for Parkinson's, but we have to remember to treat all these other things. We call them the non-motor symptoms. And the reason these occur is because Parkinson's is not just a dopamine disease. This is a misnomer that has been propagated in the literature by doctors, patients, everybody. And the reason is that if these symptoms, the stiffness and the slowness, go untreated, it really is the primary disability of people. And you focus on that. We have focused so much research and treatment on the dopamine symptoms that these other problems are starting to rise and become the issue that we have to do better at. So all these symptoms actually reflect the underlying pathology. So, as many people know, the underlying pathology is the accumulation of alpha-synuclein. It's a protein that misfolds. It gets into neurons, it clogs them up, and then they don't function properly. And that happens in dopamine neurons, and then we replace the dopamine or get them to make more dopamine, and those symptoms improve. But it turns out that those clumps of alpha-synuclein are everywhere. It's much more widespread than anybody ever thought. It turns out that it's in the GI tract very early on in the disease, probably before it even gets to the dopamine neurons. And that's why people have very slow motility of the gut. The gut moves slower, just like body moves slower. And that's why people get constipation. The blood vessels don't respond as well. They respond slower. That's why when you stand up, you get lightheaded, because your blood pressure drops, can't respond. The areas in the brain that make serotonin, and serotonin is very important in reducing depression, anxiety, sleep, and so we have to address that. So when a good doctor with Parkinson's thinks about all the non-motor symptoms as well as the motor symptoms. Now, I'm making a big deal about this, and now I'm going to go on and talk about just the motor symptoms and dopamine, just because I'm not necessarily an expert on all the different antidepressants and all that stuff, but I'm happy to answer questions on those things. But I am going to focus on the specifics that are really specific for Parkinson's disease. But again, that's not to de-emphasize the importance of treating all these non-motor symptoms the best we can. So we treat these non-motor symptoms with medications that increase, improve the transmission of dopamine. We do this with medications, and we do it with surgery. And then after I talk about those, then we'll start talking about where we are with disease-modifying therapies. So this is a cartoon about a dopamine synapse. So what happens is in our brain, we have a bunch of neurons and they talk to each other like electrical impulses. It's just in regular, wiring in
Why did you want to
electricity.
hear it? You know all this.
Please mute, everybody. So what happens is that when they release dopamine, so the electrical impulse comes down the nerve cell and it releases dopamine, it binds to a neuron that's right next to it, and then that electrical impulses keep going. So that's how we communicate, and there's not enough dopamine here, and that's why people have problems. So what we do is we can give levodopa, which is Sinemet and the main treatment, and that helps neurons that are still there make more dopamine. If you take tyrosine, we don't have enough of the enzyme to make dopamine, levodopa from it. So this is a natural amino acid that your brain makes normally, and it turns it into dopamine, and that's why we think it's still the best treatment. Then there are dopamine agonists that we have that try to be synthetic dopamine. They bind directly here, and they can help, but they have their issues as well. Then we have other places that we intervene, which are much smaller effect. The reason why I'm telling you this, and some people obviously know this already, is because we're focusing so much now on levodopa because we've tried all these other mechanisms and they don't work quite as well. So what we're trying to do now is improve levodopa. So what happens when you take a levodopa pill, a Sinemet pill, is the blood levels go up and they reach this peak in about 45 minutes. And then by about 3 hours or so, most of it's out of your system. So that's why we have to, some people have to take pills quite often, is that early on in the disease, when you take the pill, you can take it, it reaches in the brain, and your brain's able to store it. So even though the blood levels are going down, it's still working. But as time goes on, you have less ability to store it. So it spends shorter and shorter time working, and then you have to take it more frequently. So our goal is to try to make it more smooth, like it here is shown in yellow. And another way to show it is early on in the disease, when you take it, you have this benefit, this sweet spot here that's shown in this yellow area. This is what we call the therapeutic window. So when you take it, no matter how much you take, if you even take too much, you're fine. You'll feel great, you look great. And it's only until it gets to the very bottom that you start feeling slow, like it's not working. As the disease progresses, the same amount of levodopa, if it's too high, you start getting dyskinesias, those extra movements that Michael J. Fox has. And if it's too low, you get stiff and slow, the symptoms come back. So this sweet spot, or this therapeutic window, gets narrower and narrower, so that over many years, you're either too high or too low, and there's very little time in that perfect on time is what we talk about. So this is the problem with levodopa. So what we're trying to do is hopefully slow the disease down, and if we can keep it like this, we have very few problems. So we're trying to figure out ways of slowing it down, and we're also trying to figure out why some people get here faster than others. But until we do that, can we keep the drug in this sweet spot longer? So how are we trying to do that? So we have drugs like Rytary. So this is a capsule that has very short-acting levodopa, medium-acting levodopa, and long-acting levodopa. So when you take that pill, it lasts longer. So it hopefully stays in that sweet spot longer. A much more dramatic way to do this is, why not just pump it in? And that's what Duopa does. And I go through this in a little bit more detail in a minute. But what it does is it goes right to the gut, so it doesn't have to get into your stomach, have your stomach release it, and then start getting absorbed through your gut into your blood. That takes time. And then it gets degraded over time. So if we infuse it, it gets absorbed much more regularly, and you can keep nice blood levels. Then we have ways to say, well, if it breaks it down, can we block it from being broken down? So we have a drug called entacapone or Comtan. We've had that for a number of years, and that helps. Now there's a longer acting one called apicapone, which was recently approved, that slows the breakdown. Again, makes it last longer. Not long enough, but better. There are drugs, it takes time to get this to work, right? You take your pill and it may take 45 minutes to an hour to kick in. So some people, they can't move very well during that time. So is there a way to get it in faster? So there's Ambrosia, which is an inhaled form of levodopa, and it gets through the lungs much quicker, and you can get that blood level up much quicker. So if you, so what Ambrosia does is helps this time at the beginning. So instead of taking 45 minutes to get here, you can get there in 10 or 15 minutes. Where when you're talking about things like apicapone, that makes it last longer, so it doesn't come down as quickly, the slope of that. Kenobi, or a apomorphine, which is a dopamine agonist that you put under the tongue, that is another one that helps it kick in quicker. But both the Ambrosia or the apomorphine doesn't last very long. That's just a bridge till your levodopa kicks in. Now, Nouriance or istaratopine, which is a whole new class of drugs, does not work on levodopa per se. But what that does is that works here. There are other receptors here, so that when Cinemet responds here, that response in this neuron lasts longer. So it works in a very different mechanism, which is one of the things that is exciting to us, is that it's not just working by levodopa, which everything else that we use does. Apomorphine, as I mentioned here, actually works quite effective for the motor symptoms, but it doesn't last long. So we actually do infusions under the skin to make it very steady state. And now we have ones that are being tested with levodopa. So let me go through these in a little bit more detail. So Rytary, like I said, is something that lasts longer. This is some of the early studies. So this is through its scientific name under the studies. But you can see regular Cinemet, which is shown here, it goes up and then it comes down. And again, so the half-life, we say that is about 90 minutes. It comes down to half in 90 minutes. And then most of it's gone in 3 or 4 hours. It's very low. If you take Cinemet ER, it comes on slower, but lasts longer. And then if you take Rytary, it comes up quicker like regular Cinemet, and it stays up much longer. So here you have a much longer amount of blood levels. And you can see that in people that are taking it, their on time, as you would imagine, is extended. So this extends on time, so people don't have to take it quite as often or as frequently. It's not for everybody, but it is a benefit for those, especially those people that are have to take Cinemet every couple hours. It's one of the ways to reduce that need to take it every few hours. This is Duopa. So this is the one where I say where you take a tube and you actually surgically emplace it. It goes through the stomach, and there's 2 tubes. One of them stays in the stomach and another one goes into the jejunum, which is part of the small intestine. And this is where all those receptors are. The best place to absorb levodopa is in this part of the gut. That's where it is. So when you take a pill, it has to go into your stomach. It doesn't get absorbed there. The stomach has to empty, and that happens on different times. That's where food makes a big difference on how fast you empty it. Then it gets released in the small intestine, and it's only in the small intestine. That's the only place that you can absorb regular levodopa. And so there's a cartridge of liquid levodopa in here. It's actually not levodopa. It's very close to it. It gets turned into levodopa, and then it gets absorbed very quickly. And so you have to carry this around and keep this tube into your stomach. But the reason you do that is that the blood levels stay exactly the same until you turn them off. Look how nice and smooth it is. And that's our goal. That means no more up and down. It's there, and this is for 16 hours until you turn the pump off, and there it goes down as you would expect. So this is very, very effective in maintaining your blood levels. And what that means is, I didn't put a slide here, but the on time mirrors this. So that when you feel like your best on time, when you're in that sweet spot, this will put you in that sweet spot most of the day. Now, the problem with this is that this pump is pretty heavy. Everybody hates it. They complain about it. People hate the tube. It goes into your stomach, and they can get dislodged, they can get clogged, they can get infected around the skin. It's not ideal by any means. But the part that really is encouraging to me is if we can get a more acceptable way of getting these stable blood levels, it's a huge advance in this symptomatic treatment. So this has to be improved, but it's proof of concept that reaching these blood levels, and now we know what these blood levels need to be, somewhere around 3 micrograms per ml, which is really important, and I'll tell you in a second why. It's variable. That's what these lines are here. Some people it's higher, some people it's lower, and everybody's needs are differently as well. So this is the Ambrosia, the inhaled levels. So if you take Cinemet on an empty stomach, this is in blue, you can see the blood level goes up, and this is, in this case, it was about 30 minutes or so, it reached its peak. This is when somebody has been starved, they've been fasted. So it takes about 30 minutes to get to the peak, and again, a wide variation from person to person, and then it comes down slowly over time. And so this is 120 minutes, so over 2 hours, you can see how much lower it is. If you ate some food, we always talk about taking on an empty stomach. Here's a good reason why. So if you have food, look what happens in dark blue, is it never comes closer reaching that peak. And in 2 hours later, you've never really gotten much in your system. It blocks the absorption is when you eat food. But when you do Ambrosia, whether you eat or not, you inhale it, it's going through the lungs. And so you reach that peak, in 5 or 10 minutes, you've really gotten pretty significant blood levels. It stays about that level until about 45 minutes or so, and then it starts coming down. So what this does is, say it's going to take you 30 minutes for your medicine to kick in, you'd say, well, I don't want to wait that long because I got to get dressed and get out of the house. You can take the Ambrosia and get your levels up here, and then your Cinemet kicks in as this starts fading away. So that's the advantage of Ambrosia. The negative side is it doesn't have carbidopa in it, so that it doesn't work as well for the first dose of the day, because that has to be taken by pill. It's irritating to the lungs, so people cough a lot. And so most people I know cough some. And somewhere about 10 or 15% of the people, it bothers them so much they don't want to do it. You break this little capsule open, you put it in, you inhale it. Most people need 2 capsules and have to repeat it. But for some people, it's a good salvage technique. It's what we call a rescue therapy to do it. So it's very effective for some people. Unfortunately, all these new medications are very expensive. And so, the goal is not to need it, that we can bridge these drugs, the blood levels from next dose to next dose and not need this. But for the people that do need it, this can be very helpful. So this is the sublingual apomorphine, or Kinmobi, which is a weird name, and they told me why they came up with it, but I forget. The advantage of this, so apomorphine is as effective as Sinemet or levodopa, and you can see the blood levels rise pretty quickly with the sublingual. It's not as fast as Apokin, which is an injectable apomorphine, but it does work. It does get up there and does turn people on pretty quickly. It bypasses the stomach because it's not levodopa, it can get absorbed under the tongue and work pretty quickly. The problem with this, the main issue with this is it's not levodopa, it's a dopamine agonist. And dopamine agonists have additional side effects for some people. And the side effect for apomorphine, one of the ones that we worry most about is dropping blood pressure. So this can make people's blood pressure drop. And because you have Parkinson's, blood pressure already has that tendency to drop when you stand up. The other problem is nausea. So if you use it regularly, most people don't need to use an anti-nausea medication, but most people need to have it on if you're using it intermittently. So people have to take a medication called Tygan, which is an anti-nausea medication all the time. So when they need to take this, it's already on board. It doesn't help to take it when you do this because it takes longer for the anti-nausea medicine to get absorbed. So the big problem with this is you need to take an anti-nausea medication most of the time, pretty much all the time, so that when you need this, it's there. So it's helpful for some people as a rescue as well. Istaratopine film, or Noriance, is this A2A antagonist. And this is a terrible one to show you, but I'm just trying to demonstrate that what happens when we give dopamine is it binds to dopamine responsive neurons, and there's what's called the indirect and direct pathway. And what this does is bind to these receptors that are on these neurons down here and makes it last longer. So right here, it's more in the indirect pathway. So when you stimulate with dopamine, this responds longer than it normally would without this medication. So what it does is it extends on time for about an extra hour a day. And in most people, the dyskinesias don't get worse. And so this is some of the studies. And so if you see it here in red, this is the amount of off time. If you take Noriance, if you take 20 milligrams, it reduces the off time by a little over an hour compared to placebo. And if you take the 40 milligrams, it's about an hour and a half compared to placebo. This is over a 24-hour day. So it's useful, it's well tolerated in the vast majority of people. It's expensive, but it's convenient. It's once a day. And again, a different mechanism of action. So again, everything to make the levodopa last longer. It turns out it doesn't do anything unless you're taking Sinemet. So now we're getting to things that are experimental. So this is apomorphine that is approved for Apokin, where you can give an injection. It kicks in about 5 to 10 minutes and gone in an hour. You can take it under the tongue, as I showed you. Now it's approved, and it kicks in about 20 minutes and lasts for about an hour and a half. Or you can take this little pump, put it onto the skin, and pump it in all day long, and the blood levels are nice and stable. We've just finished, we're in the open label extension, a study we've done now for 3 years. And it's really smoothed out people, but because it's apomorphine, it has some side effects. We've had the most problem has been with sleepiness, a little bit of low blood pressure, but it causes some sleepiness, but it really smooths people out. The other problem is people can get these nodules under the skin. These needles have helped a lot, but that is one of the problems, but it's very useful. And this has been approved in Europe for some time now, and I expect it to be approved in this country. It reduces off time by several hours a day, so extremely effective that way. So this is, I don't have good pictures of the AbbVie product. So there are two companies that now have come up with a formulation of levodopa that can be injected under the skin, just like the apomorphine. It can now be done with levodopa. And like I said, levodopa usually is the best tolerated and the most effective. So Neuroderm, which is, I forgot which company now bought them out, but it's one of the large companies bought them out. They're in the final stages of trials, and AbbVie has one as well that in full disclosure, we're doing that trial with AbbVie. And the reason why we chose to do it with AbbVie is that we can reach those blood levels with Duopa with the AbbVie trial, where Neuroderms only can get about half that level. So they're going to have to take additional levodopa, most likely. Where with the AbbVie, if everything works out well, it's going to reach the same levels of Duopa. And if we reach the same levels without having to do a surgical tube, that's fantastic. Then you can just put it through the skin. And in the AbbVie trial, we change this every 3 days. And people won't need to take any more pills. We can adjust the infusion throughout the day to get the right levels. So this is going to be hopefully a big breakthrough instead of taking pills multiple times, and it should prevent the food effects. So you don't have to worry about taking it on an empty stomach. So these two companies are in a race to get to the finish line. They're both in phase 3 trials, and we're excited. Hopefully they both will be approved. I do want to say for disclosures, I don't personally take any money for consultation or anything from any company. So none of my decisions are made for any personal gain, but we do get money to run the trial for the AbbVie study. All right, so we have 23 minutes left, so I'll go through this pretty quickly. The approach to disease modification. So we're trying the best thing is to get to the source. What is the molecular cause of progression? And can we interfere with that? And we haven't been very good at knowing what that was until recent years. And now we're finally starting to target that. And so we're trying to do that now. Experimental models have not been great over the years, but they're getting better. So we're hoping that the things that now work in the lab are going to work in people. So we've cured Parkinson's in mice and in zebrafish millions of times. We just haven't done it yet in people. But there's good and bad about how we test this in people, because people, Parkinson's progresses very slowly, especially after the first couple of years. And so that's good. The problem is that when we test a drug, it takes a long time to determine whether it's working or not. So that's why progress is a lot slower than any of us would like. So I do want to say, and for those who've seen this before, sorry. For those who haven't seen it, it's important, and I'll reiterate this. So we actually do have something that modifies disease, and they've done double-blind controlled trials. So in this one trial, the treatment improved. So people without treatment got worse over time, over 6 months. So you can see here in dark red, they got worse. But when we did this treatment over 6 months, they actually got a little bit better. So this therapy improved people. They were better at 6 months than they were before they started the trial. In another trial, they tried a very similar approach. And so in placebo, they got worse over time. And then if they did a medium dose, they got less worse. And then at a high dose, they didn't get worse at all, basically unchanged over that 6-month period. And this treatment is exercise. So in this case, they did a stationary bike 3 days a week, fairly intensively. And if you did that, people got better over 6 months. And in this case, they did a high intensity treadmill. And again, over 6 months, the people who did it didn't get worse, the people that didn't got worse. So we have something that works already. Unfortunately, I can't prescribe it. And you go to the pharmacy and you pop a pill, which is what people want to do. But it makes a big difference, and it's been proven over and over again. The other thing is diet. And I tried to make a good slide to represent it, but I'll just tell you what it is. So there's a recent study looking at Mediterranean diet in 25,000 people. And what was really interesting was that the people that ate a Mediterranean diet over the previous 15 to 20 years had half the risk of getting Parkinson's than those that didn't. Half the risk. It blew me away, the size of this effect. And that means, Mediterranean diet is eating lots of fruits and vegetables, fish, poultry's okay, less red meat, less fried foods, using olive oil, not too much sweets, complex carbohydrates. Good diet makes a big difference, and you can do that now, and you will feel better, and the disease will progress slower. We know it. It's not just lip service. But we all would rather take a pill. It's a lot easier, or in addition to it, we should take a pill. And so there are these drugs called GLP-1 inhibitors, and they block inflammation, and I'll talk a little bit more about it. And then there are the immunotherapies. Can we use antibodies against alpha-synuclein to prevent clogging up? There's small molecules that break up these clumps that are being tested. And then there are genetic approaches. And I'm really not going to talk about these today because they're a little bit more in earlier trials. They're phase 1. These are much further along. So the reason why I like GLP-1 inhibitors is they're already on the market. So these are approved for diabetes. And in fact, this one here, liraglutide, it was just approved for weight loss as well. And it was found that exenatide, which there's a whole bunch of these now that are under development that are already approved, seem to be neuroprotective. And we've learned now that it seems to block the inflammation in the brain. So we start having we're starting to understand why this may work. We're participating, Dr. Bartolon is actually running the study on an investigational compound for people that are just diagnosed with Parkinson's to start on this one that is basically similar to exenatide, but lasts longer and is a little more selective, and see if this slows the progression. There's some other trials going on. These are phase 3 trials, so they can be moved right into the clinic very, very quickly. And in fact, if you're a bit overweight, and you have borderline diabetes, you might want to talk to your doctor about getting on one of these things, because maybe you can kill 2 birds with 1 stone here, or 3 birds. So this is some of the trials that were done with exenatide, and they were a little bit done in a different way. They were done in people that were on levodopa, so it was a little bit hard to evaluate. But in this trial, this was done in the UK, people that were on exenatide did not progress over a year, where the people that were on placebo did. There's been 2 trials like this that have demonstrated this. So it's been pretty encouraging. The differences are relatively small, and it's like I said, it was a trial that had a bit of an unusual design. But if you look at MRI, this is a functional MRI, it actually improved some objective measures. And that's really important because this kind of gets around some of the problems we had with the study. So this is not going to stop it cold, but maybe it's going to slow it down some. So this is why I'm enthusiastic about this. And then the antibody trials are very, very encouraging. So there's one where it's like an immunization, like with COVID, you get a vaccine, and in this way, the vaccine targets alpha-synuclein, and it's gotten through the phase 1 trials. We're waiting for the phase 2. This has been mostly developed in Europe and Australia and Austria, but the antibody trials where you infuse the antibody target against alpha-synuclein have been developed by 2 companies. This is exactly the same approach that that was used for Alzheimer's disease, and that drug was just approved. The Biogen antibody against A beta. So A beta is the alpha-synuclein of Alzheimer's disease, and that has been shown to slow the progression of Alzheimer's when given very, very early. And it clears the A beta from the brain. And so we're hoping this is going to happen in Parkinson's as well. So the bad news is that the Biogen trial was stopped due to futility. The Prothena trial is a little more optimistic. And if you look here, the people getting the highest dose in infusions did better relative to the placebo. So you can see that they progress slower relative to placebo. So this is encouraging. Not all antibodies are the same. And as with the A beta trials, that they had about 5 or 6 different failures before they found one that actually worked. Lilly had a different antibody. They dumped it. They have a new one that looks even better, probably better than the Biogen. So we're very, very excited about just the beginning of actually seeing we're moving the goalpost. So I think I'm going to stop there. I have a few other things I can talk about, but I think I'm going to stop there so that I can take some questions.
Okay.
All right, I'm going to stop sharing.
Okay.
And open it up. So I don't know, Patrick, do you want me to read from the chat or do you want to moderate?
I'm happy to moderate, and
That
yeah,
would
why
be
don't
great. And help select ones that you think are going to be of interest to everybody.
Got it. Okay, so this is from Bob, our Bob Potter here. Can you talk a little bit about what has precipitated the rise in the incidence of Parkinson's?
Yeah, so that's a great question. There is a rise in incidence. There's one clear reason is that people are getting older. We're curing heart disease and stroke and that sort of thing. So people are living longer, and age is a risk factor. So if you get more people that make it to 80 or 90, the more people are going to get Parkinson's. But that's only part of the story. People are getting are definitely a higher incidence despite that. So this is what I study, and I believe environmental toxins are the cause. So these are things that we were exposed probably 20, 30 years ago over a long period of time. So pesticides have definitely been linked in a variety of ones, and that's what I study and which ones do it. But air pollution, I think it's a big one, and we've been exposed to a lot. We've just published a couple papers on this, and more coming out. So I think air pollution increases the risk, and it's for such a huge number of people, it can explain a lot of that increase. So I think it's environmental causes are the primary reason, and we're trying to figure it out.
Okay, great. What research is being done into gait issues? Any new medication or treatments in the pipeline? And I don't know if this is a typo, but same question for punding, P-U-N-D-I-N-G. I'm not sure what that is. But.
Okay, I'll tell you about punding in a minute. So the gait problems are really interesting. So as we talk about off time and on time. So off time is when the medicine is low and it's not working. So the way we try to improve gait problems when you're off is to make you on more time. So we extend the length with a COMT inhibitor, give Nourions, give a pump. All of these things improve on time, all those medications that I referred to. But unfortunately, some people still have freezing of gait, and despite that. And it's a really difficult problem to get at because we can queue and it's people freeze in doorways and in elevators, but in open space, they can walk fine. So how do they do that? So we're trying to figure out, how do you use different circuits in the brain to do it? In fact, one of our new faculty, Katie Cross, is studying this. We've been doing stimulations of different parts of the brain in the operating room when we do DBS, to see if we can figure out different circuits to get there. So there's a lot of work to try to use different circuits that we use that work even when people have on-time freezing. Unfortunately, gait is really complicated. So there are many aspects of gait that can go wrong. So using these other circuits, and that's one of the ways that physical therapy and exercise probably help gait, is by tapping into these other circuits. It's through that repetition. So that's one reason we think it's so important to exercise. But some of the things like balance, that's a big one, right? When people have problems falling backwards, even when they're based on, and we know that's due to damage of the brain in other parts of the brain, and medications don't treat that. And we don't have a good way to do that right now. So the best answer for those parts of the problems are that we're trying to prevent the progression to get there, so that if we can stop it before it progresses to that part of the brain, it won't be an issue anymore.
Great. Marty asks.
Punding, I didn't answer punding. So punding is when people get into these hobbies and repeat things. It's kind of a compulsion. So this is, most of the punding issues are actually from overstimulation, like the compulsions that people get from dopamine agonists. It's from stimulating different parts of the brain with dopamine that don't need it. It's rewarding. So when we're trying to get more to the areas that need it, it gets to everywhere. And so the problem with punding is we're over treating other parts of the brain. And so the best way to treat punding, it's usually when people are on a dopamine agonist. So it's lowering the dopamine agonist or even getting off of it. So I think of punding as a compulsion, like the gambling, shopping, sexual stuff. Those are compulsions. Punding is in that category.
Okay, thank you. Marty asks, my husband has mental issues as well, like dementia. You didn't mention that as a symptom. Is dementia related to his Parkinson's?
So the answer is yes, it can be. So, so for one thing, terms are really important. Dementia is not a yes or no. I like to talk about it as cognitive ability. So cognitive impairment, it's a spectrum. So if you don't have Parkinson's disease, we all slow down a little bit, right? We all have problems, especially with retrieval, with memory, I forget his name, that sort of thing. That is part of the aging process, and that's normal. If you don't have any disease, about 15% of people are going to get demented by the time they're about 70, 75. If you have Parkinson's disease, that risk doubles. It goes up to about 30. So dementia is a term that we use when the cognitive impairment gets to a point where it really significantly interferes with people's ability to carry on their daily life. So I like to call it cognitive impairment because there's a spectrum. There's mild cognitive impairment and different amounts. So yes, Parkinson's is associated with a higher incidence of it, but it's not inevitable for everybody. And we know that if you exercise and all the things we talk about, if we slow the progression down with all those things, keeping your mind active, you will lower your chance of getting cognitive impairment. And when you do get it, it won't be as severe. But it sucks when you get it. It's as simple as that, to use a medical term. We have some medicines that help, but it's not a huge difference. We have new medicines I didn't talk about, things like pimavanserin or Nuplazid to help with hallucinations, which can be part of cognitive impairment, and it's a side effect of the medications. So we are trying to address it, but it's really hard. Cognition is a big problem. So we're hoping that getting rid, and that's with the disease now affecting the outer parts, the cortical part of the brain. And that's when the disease has spread pretty much throughout the nervous system.
Okay, so Steve asked, I had DBS in June 2018 and now see different newer Medtronics systems out there. Is there a marked difference in the symptom relief using the newer symptoms hitting the market, and can one upgrade their system?
Good question. So there are now 3 companies that make DBS. They all have slight positives and negatives, but sorry about the pun. They all are about the same in the way of their ability to treat symptoms. So if you have optimal DBS, if you have a system from 1998 compared to now, the outcomes are going to be pretty close to the same. The advantages of some of these are a little bit subtle. So the newest Medtronic just came out a week ago, where they have what's called segmented leads. So if you have problems with side effects, you can steer the current around those problems. So that when you're stimulating, normally it's like a whole ball. And in the Abbott or Boston Scientific, which already have the segmented leads, you can push the current to the areas you want to stimulate and keep it away from the areas you don't want to stimulate. The areas you don't want to stimulate give you the side effects. So we can steer it in the right direction. So now all 3 companies now can steer it. You need to have one of those electrodes in your brain with the segmented leads to be able to steer. So you're not going to be able to upgrade that part of it. The stimulator that's in your chest has also been changing. So the Medtronic is the only one where they can actually measure brain activity in your brain. So they can measure the activity that changes. And we think that if we know what that is, we can then customize the stimulation to respond to that. So right now, when we stimulate the brain, it's stimulating the same all day long, 24/7, whether you need it or not. So the idea is can we stimulate only when you need it? And so what it does is record from deep in your brain and say, okay, now we need it. Can we now stimulate and turn it on? So we won't program it anymore. Is the brain is going to tell it when to stimulate. It's called closed loop. It's not there yet, but they have put it in the system so that when they're ready to put that in there, it'll be ready. So that's in studies right now. So that measuring local field potentials is not going to be something that that helps right now, but might in the future. That should be compatible with your system. Now, the Abbott has steering. What's nice about the Abbott is it has steering. Your patient controller is nice. It's an iPod. It's Apple. And the newest thing that they can do now is we can now program over the internet. So you don't even need to come in. We can program it through the internet now with the Abbott. That's the only one. Boston Scientific has a really nice rechargeable one for people that need a lot of juice. We can give them a rechargeable one. You don't have to change it. And they have a certain way advantage of how we can program that might help for some rare cases. But the bottom line is, if we were to do a big study and look at the systems from 20 years ago to the systems today, the outcomes are going to be about the same. There are some people that are going to be a little bit better, a little bit more comfortable. We can help with some of the side effects a little bit more, but it's not a huge difference. So don't feel bad that I got it 2 years ago. You're gonna benefit from the advances.
Okay, quick one. Donna asks, does Rytary also need to be taken on an empty stomach?
It helps. So yes, it works better on an empty stomach.
Okay. We're kind of running low on time here, but what do you think of Calitrio and other bracelets to treat PD tremor, or other wearable non-invasive devices on the market or in development?
So there's some in development. You know, in general, I think of the tremor control as being less important in the sense of function, because it tends to get better when you're moving. But yes, there are wearable devices. I don't know the one that you're talking about there. The other, I've never seen one that really helped that much yet to make it worth it. The most important wearable device that we have now is called the PKG, which is the personal kinetograph, which is one that helps record your symptoms, and that helps us monitor the medication. So that's something that is available. We did the trials for years. It's now on the market. You have to do it through your doctor, but that will record your tremor, your dyskinesias, your off time over a 6-day period, so we can help monitor therapy that way.
Okay.
Can we do a verbal question?
Yeah, go ahead, Bill.
The stem, can you address, Doctor, thank you, by the way. Can you address the stem cell operation?
Sure. Do I have a couple minutes if people?
Yeah, I mean, I think we're all good to go. If you have a couple more minutes, Dr. Bronstein, that would be awesome.
Let me just check my schedule real quick to see what I'm supposed to be. Okay, I'm okay for a little while longer. So,
okay. I will just go for 5 more minutes, and I'm going to apologize in advance because we got a lot of questions here, guys. We're trying to get to everything, but if we don't get to your question, I apologize. You can ask it through the email. Maybe we can get it answered.
Okay, so I'm sharing this because I had this as part of my slide if I wanted to. So we've learned some lessons. We did transplantation years ago. It was called fetal cell, but those were neurostem cells. And what we learned is we can transplant them into the places where we need the dopamine, and they live and they can make dopamine. They can improve symptoms, but the problem was they couldn't control the release. So people got the involuntary movements. They're called runaway dyskinesias. And most of those people actually needed to get DBS to control those. And then other people didn't get benefit at all. And then ultimately those transplanted cells actually got Lewy bodies. The disease spread to the transplanted cells. So the hope with stem cells is that no longer do you need to get fetal cells, but we can get them from the skin or from the blood, or perpetuated in the line, in a cell line, transplant them in. One problem we worried about with the fetal cells is they're actually making serotonin and not dopamine. So we can hopefully direct these stem cells before we implant them to say, no, they're only going to make dopamine, and maybe they will help. So the idea is we can deliver them better, and hopefully those are going to improve the symptoms. There is a trial that's just starting. That may be the one that is referring to a new chair at UC Irvine. Clara Henchcliffe is there, and she's going to be a site for this trial. And so they're going to start putting it in. So it's still only going to treat those off-time symptoms. It's going to treat the same things that DBS does. So it's not a cure. So if you have memory problems in the other part of the brain, it's not going to fix that. It's not going to fix balance problems. It's not going to stop the progression. It does the same things that DBS does. So the real advantage in the long run for me for stem cells is, yes, this may help people in treating the symptoms just like DBS and improving it, and infusions will, all those things. But for me, it's we can take your cells, put it in a dish and figure out why you got Parkinson's. What is it for you? And can we give you a disease modifying therapy that is directed towards your cause? And that is really coming along. And that's the hope of stem cells, in my opinion. That's the big factor for that.
Okay, thanks for that question, Bill. I'm going to open it up for one more verbal question here. And I hope I'm not creating a huge issue by doing that. So if you would like to unmute yourself, the first one gets it. Okay, since let me just jump to one last question here. Could long-term use of dexedrine contribute to Parkinson's?
So there's no evidence that it does. So the answer is no, and it can help the symptoms actually a little bit. I'm not promoting dexedrine because it's bad for other things, but don't worry about it in the sense of making Parkinson's worse.
All right. Well, thank you very much, Dr. Bronstein. Is there anything else that you would like to say to us before we wrap it up here?
Yeah, so I do want to say that, you know, I've given talks now for 25, 30 years, and I'm always optimistic. Things are on, and I look back and I think about, you know, kind of what's happened over the years. And so what's happened now is that we've definitely improved the quality of people's lives by improving the dopamine medications. You know, DBS has been a huge breakthrough and improved people. We now have, with this breakthrough with Alzheimer's disease, which is much harder to slow the progression than Parkinson's for many reasons. It should be much harder. They finally have gotten a treatment that has an effect. So just showing that that's possible is huge. And so when I was a resident, I would see people doing things like liver transplant, and very few people live through it. Now it's routine. We do hundreds of them a day. People live a normal life with liver transplants. There's a technique called ECMO. You know, you may have heard of it because of COVID, which is basically an artificial lung. Nobody ever survived ECMO forever. And I was like, what the hell are you doing this for? Everybody's dying. You're torturing people. It saved tens of thousands of lives during COVID. Now it's routine, and people now get it and they get their lung transplant. So the fact that you can do it at all is a beginning of improving it so that it becomes routine and works well. And I think this breakthrough with this new drug for Alzheimer's disease is demonstration that we can do it. It's the very earliest part of that breakthrough. And we are there. We're moving the needle, and it's not enough. It's never enough, but it really is happening. You just have to step back and look at the big picture and say, yes, we've come a long way. I doubt you're going to wake up like with cancer. People don't realize we've cured 80% of childhood cancer. And when you think about cancer, you don't think, hey, we cured cancer. It's been a stepwise process to get there. And we've moved a long way in Parkinson's already. So until they're done, you exercise, you eat well. I want to do one thing, if you let me have this thing. I'm gonna turn off something. Let me, okay, so you can see where I'm working from. This is my office. What do you see? You see my weights. You see my rowing machine. I practice what I preach. I've learned, I believe in this. I learn from it. I exercise every day. I watch my weight. I eat well. It makes a big difference. It really does. And every patient I know, my 90-year-old patients that are skiing and out there living a high quality of life, they're all people that are physically and mentally active. And so you can do something about it now and not wait till the pill is there. So that's my pitch. And it's not just because Patrick, this is what Patrick does for a living. I take it to heart, believe me. I have perspective in this job, and all you people have helped me for myself.
Well, Dr. Bronstein, thank you for your positive attitude. I mean, that closing was just beautiful. I think everybody agrees with that. Thank you for your presentation. And thank you for bringing us into your home, showing us your office. This was just amazing. So thank you, everyone. And Dr. Bronstein, it's been so wonderful to know you through the years. And thank you for everything you do for our community. Deeply appreciated.
It's a pleasure. Thank you for doing all this and everything you do. And we're opening up. Let's make this a great year. It's a time to rethink how we're living our lives. And so let's come out of it better. So with that, I'm going to say goodbye. Take care. Enjoy the beautiful weather, those in Southern California.
Yes, thank you, Dr. Bronstein.
Thank you, Doctor.
And thank you, everyone, for joining us today for Let's Talk Parkinson's. We have an upcoming online events, medical and surgical treatments for Parkinson's, speech therapy, nutrition for Parkinson's, and more. So stay tuned to your email inbox for these updates. This program, Let's Talk Parkinson's, is made possible by our sponsors, Abbott, AbbVie, Boston Scientific, Medtronic, Synovian, and most importantly, by you. By donating, you can help us. You can join us in this mission to improve lives of the families in our community who are living with Parkinson's. PCLA is a nonprofit, and all donations are tax deductible. If you enjoyed this presentation, please consider donating at PCLA.org and help us continue our work. And as always, reach out to us with questions if you have them at info@PCLA.org or by phone at 310-880-3143. And thanks to everyone. Stay safe and stay well.
Thank you. Bye.
Thank you.